I'm Dr. Robert M. Liesman, DPM, specializing in diabetic wound care, limb preservation, and foot and ankle surgery at Champion Health System. Today, we're covering neurotrophic arthropathy, a serious joint condition often linked to diabetes and nerve damage. Let's discuss what it is, how to recognize it, and the best treatment options.
It is around. I have found it already in just a few short weeks, a couple of really good cases. So I'm going to kind of go through this. It's got a bunch of different names, neurotrophic arthropathy, Charcot foot, etc. But this is the zebra that you want to know, okay? You want to know this zebra, not this zebra, okay? And it gets kind of complicated because it's really a vasomotor phenomenon, and but it's also, a lot of cellular and physiology that goes on with the Charcot foot. There's a number of different conditions underlying that can cause it. I don't know that obviously diabetes with neuropathy. Don't know I've seen a case of idiopathic neuropathy. I have diagnosed syphilis in the patient, very funny story, but never seen Charcot. Leprosy, we know a bit about that because the Hansen's Leprosy Center in Carville, Dr. Paul Brand, he treated leprosy with total contact casts, and we adopted that in diabetic foot medicine. So I have seen a case of alcoholic neuropathy, and it surprisingly looked a lot like diabetic Charcot. So, and it was pretty bad. It was pretty evident that he had no other cause. So what is it? It is a syndrome in patients who have peripheral neuropathy or loss of sensation in the foot and ankle. They may experience fractures, dislocations of bones, and joints with minimal or no trauma. It was essentially discovered or brought to light. You got a bunch of different names: Charcot foot, Charcot joint, neuropeptide arthropathy, Charcot neuroarthropathy, Charcot neuropathic osteoarthropathy. I mean, just on and on. I like to call it DNOAP, diabetic neurotrophic osteoarthropathy. This condition, I'm going to kind of show you how it ties in to what we do or what you guys are doing, and how it really fits into this clinic, and it's really something we should know about. So he was the first to describe the arthropathies associated, everybody's heard of, like tabes dorsalis and Charcot-Marie tooth disease. And this is back in the day when these guys were seeing these symptoms over and over and over again with these patients, and were smart enough to understand that they had common causes. So essentially, it's a sympathetic failure with blood flow due to AV anastomosis. We see bone demineralization causing osteopenia and susceptibility to minor recurrent fractures. I'm going to kind of show you how it all ties in. But here's your causes: tabes, leprosy. We're obviously not going to see chronic alcoholism. Yes, but circulatory changes may cause resorption of bone, weakening of the bone, increasing susceptibility to fracture and dislocation. I'm going to kind of explain that further. So we've got a combination with diabetic neuropathy. You've got sensory, you've got your motor, you have trauma. Now, this is going to be described in more detail as microtrauma. Obviously, your autonomic neuropathy, which decreases the capacity of the blood vessels to regulate flow and constrict and control the amount of flow. So you've got lack of neuropeptide regulation. Now, incidence, kind of been all over the place, kind of depends where you are, how much you're diagnosed. Going to be different, obviously, in a diabetic foot center. 28% of diabetics reportedly have peripheral neuropathy, and the prevalence of Charcot is 1% of patients with peripheral neuropathy. You can see there's a range, and as high as been reported as 13%, and as high as 29% of patients with diabetic peripheral neuropathy. But believe it or not, in a diabetic population, it's not nothing. I have treated and managed literally hundreds and hundreds of cases of this over the years. It wouldn't be uncommon for me to have, a couple of acute cases going on at one time, and then multiple patients with diabetic foot ulcers and multiple reconstructive patients going on at the same time. So this is interesting, and I thought you guys might appreciate this. There was a case in 2023 that they found after they had revascularized a patient bilaterally, the patient developed bilateral neurotrophic arthropathy. So I kind of was a little bit suspect because the right limb, the first limb that they did, the diagnosis came up in 8 months, 8 months later. So, is that a stretch or, and here's what it tells us. An unusually good blood supply and peripheral neuropathy are reportedly accepted prerequisites for the pathogenesis of Charcot. There's anecdotal evidence, and I can tell you, I've obviously wondered about this. There's all kinds of things that can kick it off. But, you can only imagine that revascularizing somebody absolutely could, because as I said, an unusually good blood supply has to be there pretty much. So the first case of a person with diabetes who presented, and they're making a case out of this because it was bilaterally. So the patient developed bilateral Charcot after revascularization. Kind of interesting. So they don't need to present like this, I promise you. But if we miss them or we don't diagnose them or they're out in the community, don't have access to care where they can be found, I pretty much can tell you eventually a percentage of them, some will look like this. It is fascinating that some will do this and it is wickedly progressive and destructive, and some kind of stabilize on their own and coalesce. I have some ideas and theories about why that happens, but there's just different types of patients, as you guys know, we see with a lot of stuff. So more likely it'll present to look like this. Now, this is just kind of modest degree of erythema. Calor is present, and we are able with a handheld thermography to be able to just detect the diagnosis is 2 to 4 degrees plus compared to the contralateral foot. But you look at a foot like this presents, and this is what it looks like inside. I cannot impress upon you how bad this really is. This has 1, 2, 3, 4, 5 Lisfranc's joints, 1, 2, 3 or 4 mid-tarsal joints, 2 hindfoot joints, and it's pretty much affected the entire midfoot and hindfoot. So you got nearly every joint through this entire region of the foot that's basically destroyed. There's nothing left. They're displaced, dislocated, and degenerative. Pain, minimal, sometimes. So that's really important. Swelling, yes, almost always. So interestingly, I kind of highlighted these here because let's just look at that foot. We're all practitioners for many, many years, and you could say any of the above: gout, cellulitis, fracture injury, venous disease, DVT, a bug bite, deep space infection, contact dermatitis, sunburn, shoe irritation, etc. Atopic dermatitis. I don't think there's anybody that would disagree that any one of those diagnoses could be presumptive when you see a foot like this. I'm going to say to you and go on a limb and say there's nothing nebulous about the diagnosis. From my viewpoint, and this is my perch, I'll usually put it and nail it every time on the top of the list, in the top 1 or 2 or 3 maximum. I'm not special. I just see a lot of it, okay? Now, your symptoms, you're gonna see redness, warmth, swelling, obviously. Deformities in the collapse of the midfoot, instability of the hindfoot and ankle. I'm gonna kind of go through this and tell you when you will actually see it and what it really is gonna look like. It can look like this, but a couple of key factors, if you take away that erythema, what you'll see with this foot is that is classic, okay? And these are pearls. You're not really gonna see a lot of this in the literature. I'm just telling you that medial lump and collapse of the arch. Now, this is a bad place to be already, but still, this is in the acute phase, but you can see all that all that dark area is bony resorption. Okay, so we get up to this, and this, what's fascinating about it is often missed It'll go on for several weeks or months, if ever it's diagnosed. They can mimic injury infection. Interestingly, patients may get better from swelling. Doctors put them in the hospital, put them on IV antibiotics. Somebody put them in a boot. Somebody tell them to stay off their foot. Patients themselves might say, well, my foot was swollen, didn't really hurt, whatever. And they just, chilled out and took some rest. Or they may be kind of sedentary to begin with. And that brings up a whole different area of complications that, if somebody's sedentary and is walking on a foot that they're not walking a lot on, obviously you're going to get some weakness of the bone as well. So other thing, I've seen colleagues have these cases blow up on them. They do a reconstructive surgery of some kind and they cast the patient for a few months or whatever, a couple of months, and they take them out of a cast and then they go ahead and just tell them to start walking. Well, you've got to restore weight bearing. We've treated Charcot and seen them walk on it afterwards. So the severity deformity includes collapse of the midfoot, called a rocker bottom. And these are the really, really pronounced deformities. The way to catch these cases inside of a diabetic foot center, the reason why I catch them is because these people are coming in for their routine. Do we love doing toenails and calluses and all that? No. But what it does is it allows us to keep an eye on these patients. And when they are neuropathic to this degree, we can catch them. And, some of them will just continue to monitor skin temperatures at those joints for up to years sometimes to catch these things if they start heating up. And we do. But this is, a classic Charcot rocker bottom foot. I'll be able to show you kind of why they get like that. I'll show you kind of why this gets like that. Now, you're not going to mistake this necessarily in your setting and say, well, this is something different about this. Does everybody agree with that? Does everybody agree?
Yeah.
Something different, right?
Yeah.
So you're not going to jump ahead and say, well, this is venous disease. I mean, we know it could be, so there's probably a component. But I want to present, so there were 60 patients evaluated recently in a rural health setting. No x-rays were done as part of a regular diabetic foot screening or part of a diabetic assessment. I saw 2 cases that I thought were highly suspicious, and they were sent for local hospital x-rays. And so this is the healthy foot, and you can probably see, I think there's a better way to, okay, you can see there's a little bit of degenerative arthritis, a little bit of hind foot. This foot pronates, which means it flattens out a little bit. There's a benign heel spur, but you can see your arch. High elevation, that angle of the heel bone, and the nice healthy angle of the foot. This was this lady's original foot. I'm sorry, here's her usual cocktail or usual medical problems. And interestingly, there's her vascular history, venous and vascular history. Here's her foot. What's special? So it's flattened. There's a lump right here. There's that kind of bizarre little bit of curvature. It's just generally larger. And, it just looks like a different size. It looks like one of those like flattened elephant feet. Here's her x-ray. By comparison, and she's just walking around. All she knows is she's got a little swollen foot. What's going on here? Her entire foot and arch have collapsed. Her talus, that's her talus right here. That talus should be right here. Instead, it's vertical. Radiologists called it a vertical talus. Interestingly, the local radiologist didn't take the jump and call it a neurotrophic arthropathy. I can guarantee you it was. But he defined all of the destruction and arthritis in the hind foot without making the jump. Okay, so probably because they're not seeing it. Diagnosis is missed 25 to 50% of cases. Chronic edema, arch structural, medial or plantar prominence, and an abducted forefoot, meaning it's the medial or hind foot is headed to Miami and the forefoot is going to Phoenix. That's, what you see. Now those Those are pretty severe presentations, mind you, but the subtleties are another story. So as I said before, at least in my world, the diagnosis is pretty evident. History is critically important. It is very important by history. When did it get swollen? What precipitated it? How long has it been swollen? What does it look like? What does it feel like? So is there edema? Is there structural change? Is there erythema? Any increased temperatures or calor? Were there plain film x-rays done? What do they look like? MRI is clearly going to be your gold standard, but where we run into problems with diagnosis is when you have, an MRI that could be equivocal. You have a patient that could be infected, they could have osteo, or they could have Charcot. And so there was a time when we regularly would do like an indium and a gallium scan and compare the two. Now, we pretty much, at least in my world, I make the diagnosis pretty much by MR, but clinical history is probably one of your most important things. I'll tell you that a lot of times you may have several different things on top of each other. So you could have with these foot with a hole in them, you can have cellulitis, you can have an osteo, and you can have a Charcot. And sometimes when you look at the films of this kind of foot, it's multiple different areas and they've got different things. So you can see the penetrating ulcer into the bone with the changes consistent with osteo. And then you can see the Charcot changes in the rest of the foot and the hind foot. So like this, I'm showing this picture not because it's a collapsed foot and a Charcot, but there's just, if you look at that skin and you look at the color, there's not going to be any hair growth all the way up the legs because of the neuropathy. Interestingly, they're reasonably well perfused. They generally will have good ABIs. Sometimes their ABIs are going to be well over, 1.25, suggestive of calcification. But here are the pearls. And these folks are obese, and they're usually tall. They're pretty tall. And their A1C, I have found invariably at some point in their history was over, let's just even say 10, 11, or 12. There was a fairly good period when they were unmanaged. They have good blood flow. They're insensate. It'll present unilaterally. Very, very rare to see bilateral Charcot. But when you start treating one and now you're weight bearing on the other, you can have problems. And we see structural change, and obviously those changes on the radiographs. So your X-ray findings are you almost can't miss them, but it's pretty clear that this entire forefoot is dislocated on the rear foot, and the entire rear foot is headed down plantar grade. So you're going to see the osteopenia, which is washing out of the bone. You're going to see structural change. You're going to see osteophytosis, bone spurring, bone fragmentation, soft tissue edema, shortening of the foot even, dorsal plantar dislocation of the foot, and you're going to see wounds starting. So I'm going to leave some time for changes and rip through these slides, but it is not uncommon for us to see stuff like this just walking in and out of a clinic like this, or a clinic like yours. Unilateral swelling, displacement, dislocation, bony prominences, X-ray findings of bone changes, neuropathic patients, large stature, obese, history of A1C with good blood supply, as we talked about earlier. So then, unfortunately, we see this. I've had many cases over the years of this. They will ulcerate the medial side of their ankle, get it into bone. We want to avoid this. This disorder can occur and progress in a matter of days from an ankle sprain, a matter of days from a simple ankle sprain. So if you treat, in my profession, if we treat a patient with neurotrophic, diabetes with neuropathy, they walk in, I sprained my ankle, you take an X-ray, it looks benign, you better be thinking about Charcot. You better, and you can almost expect it. So it's almost obligatory to immobilize that foot from a simple ankle sprain. And from a referral standpoint, we like to see these folks in 24 hours because that foot can do this. You can see this on a Wednesday, and then somebody sees them somewhere else on a Tuesday, and that's what the foot can start to look like, complete dislocation of the hind foot ankle. So, we can do a lot these days with external fixation. You can see this like profound midfoot and hindfoot destruction. And even, well, that's internal fixation, sorry. But, you know, throwing some of these external fixators, I did them for years. We went ahead, you just don't even have to split them open like this. You run some pins through and you can stabilize and compress the foot. You can get some really nice long-term results, okay? So, you know, your treatment is sort of a whole nother discussion and lecture, but immobilization, immediately rest, educating the patient, proper scans and studies, you know, biomarkers, yes and no, blood tests and stuff like that, yes and no. It's a story for another day. You know, that's Charcot. There's no joints in the forefoot left. There's no MPJ, first MPJ joints. It affects multiple different areas and multiple different joints. So, you know, with that, MRI is always helpful. You know, let's see, there's another one, dislocated, another swollen foot. And with that, so this, you know, just keep in mind, I saw 2 patients out of 60, the first 60 that were seen up here, looked like the foot kind of looked like that was collapsed. Patient really didn't know how this happened, why their foot was swollen, you know, what precipitated it, but with taking a good history, plus the history of diabetes, elevated A1C and peripheral neuropathy, x-rays confirmed pretty severe neurotrophic arthropathy. But, you know, she's pretty well functional, but, you know, this is constantly remodeling. So in the long run, she probably could use sometimes an AFO, like one of those Forrest Gump braces, and sometimes, you know, a proper orthotic shoe, but certainly monitoring and managing bony prominences and areas of risk of ulceration infection. So with that, I'll turn it over to any questions or comments, and thank you for the opportunity to present. I'm very passionate about that condition. So.
Yeah, good presentation as usual. Let us see if you guys have any questions on the foot.
Oh, that was great. I didn't realize the acuity of it, and so I'll be a little bit more vigilant.
You know, Dr. Dow, you're going to see unilateral swelling all day long. You're going to see it. You know the rub with your venous cases, and you know the rub with your arterial cases and your regular limb stuff. It gets pretty distinct when you get down to that foot and ankle. So I think the take-home message is, you know, unilateral edema, you have to add in a diabetic with some neuropathy, which people may not know they have neuropathy, but with that A1C and these sort of like poorly managed, obese, elevated diabetic patients, that's where you want to look. So, you know, hopefully that'll help this area, because I think it's being missed up. As I said, radiology missed it outright, you know. So anyway, any other questions?
Can we get a copy of some of these pictures?
Sure. I mean, I can put the lecture. Is there a place to put these lectures up or share them? I'll figure it out.
Yeah, so his lecture will be available on our website, but if you want the slides, Dr. Liesman can share with you.
Okay, perfect.
Anyone else?
Okay.
All right. Thank you. Thanks very much for the opportunity.
Yeah, thank you, Dr. Liesman. So next week we have a lecture. Is it you presenting? Who is presenting next week? Is that? I think it's Lacey is presenting next week. Am I right, Lacey? Oh, it's Lacey's not in the chat.
I can take a look here. Hold on.
Yeah, so I'm just looking. I'm not sure, you know, whether Lacey's able to hear us. Okay. Just checking on this one. Okay.
Next week is vein. It says, let's see, wait. Charcot, and then it looks like valvular heart.
Oh, valvular heart disease. Okay, this is going to be Rhonda will be the one who will be presenting next week. So, okay, that's good. So the same thing, yeah, 12:30, 12:30 to 1. Yeah, Rhonda is texting me. She can hear, but she cannot respond. Okay. Good.
I have one other comment. If anybody, my cell number, you can contact me 24/7 for any patient that has a potential diabetic foot complication. It's really the best outcomes come from early and immediate intervention. So please, if you have some suspected Charcot, diabetic foot infection or wound or anything like that, feel free to text or call 704-208-9238. 704-208-9238.
So, yeah, he's also in our group text message. Dr. Liesman is in our text message group also. So you guys can contact him.
I'm here with Rhonda, and Rhonda is on for next week.
Okay, good. So next week is going to be next week. Yeah, next week.
I couldn't get my volume to turn on.
Oh, no problems. Okay, next week is going to be Rhonda. Rhonda will be doing valvular heart disease next week, and Lacey will be doing on 20th. It'll be varicose veins, and
Yes.
I think Dr. Liesman will be on 27th for the second part of this lecture. And
Okay.
send me an email, if you guys have, like any topic that Dr. Sundar and Anita, if you have any topics that you are near and dear to your heart, please send me an email so we can put you on a teaching schedule, at least, so that you can spread your knowledge to all of us.
Sure.
Okay. Thank you all. We'll talk to you next Thursday.
Thank you, everybody.
Bye-bye.
Thanks, Chris. Bye.
Early detection is key to managing neurotrophic arthropathy and preventing complications. If you or a loved one has symptoms, don't wait. Schedule a consultation today. Early detection is key to managing neurotrophic arthropathy and preventing complications.